respiratory disorders. We are going to see many different disorders related to with respiratory. Okay, so we are going to go a little bit faster through the slides because some of them are just easy to read, but I want to stop in those points where explanation will be helping. Okay, these are the different objectives for today. These are the diseases that we are going to see, and these are definitions. Okay, definitions. Most of these definitions we already have seen them. So if you are not familiar with any of the definitions, I think that you are familiar with all of them. But you can review those definitions because it will help you to understand the signs and symptoms of some of the diseases that we are going to see today. Let's start with respiratory tract infections. We are going to start with the upper respiratory system, and then we will continue with other diseases that are related with the lower respiratory system. So common cold. Everybody is familiar with the cold, right? It seems like we have cold all winter long. You have a question?
So for the definitions, like, are we supposed to just look them up on our own, or?
I mean, those definitions, most of them we have seen them already. Most of them. So you just go through through them. If you are not familiar with some of them, just look at them. Yes. And you can ask me at the end of the class if you want to. Okay? Or next week. That's fine too. If you don't find the explanation or you think that you are not good with the explanation. So cold. So adults, usually we get about 2 to 3 colds per year, some of us more, and the children even more, you know, like even up to 8 or even more colds per year. You know, some of them that they go to daycare, it seems that they are in a constant cold the whole winter. And these colds are always caused by viruses, okay? Different kind of viruses, but they are caused by virus and no bacteria. So one thing that we have to keep in mind is that to treat those colds, we don't need antibiotics, okay? Very important. We don't need antibiotics. We just need to rest, take a lot of fluids, and make sure that we don't spread our cold to other people, right? But we don't need antibiotics. The only reason why we need antibiotics when we have a cold is when we don't get better. When actually instead of getting better, we are getting worse. I was okay last week. I had a cold, but this week I have a fever, and I have so much purulent discharge from my nose, and I feel like I cannot get out of the bed. Maybe at that point, the cold has become into something else, and then there is more like a bacterial infection, and at that point, you may be prescribed antibiotics. But if it's just a cold, we don't need antibiotics. Read about the different viruses that can cause cold. One interesting thing about these viruses is that these RSV, some research link the infections of those of children with RSV to later on having asthma, okay? Yeah, there are some research studies where if they get one of those colds when they are younger than 2 years or 3 years, I don't remember right now, they may actually in the future get asthma. So they have a higher risk of getting asthma in the future. Everybody knows how the cold is transmitted, right? So we should be sneezing in our elbow and coughing in our elbow, not in our hands, because if I cough on my hand and then I open the door, the next person that is going to come behind me and open the door again is going to then get all this infection. So we should cough in our elbow, and because the way that this virus enters the body is through the nasal mucosa and also through the eyes, okay? So if I go to take the elevator in my building, and then the previous person had a cold, and then cough in the hands, and then touch the button of the elevator, and then I go behind that person and I touch the button of the elevator, and then I have my eye is itchy and I start touching my eye, there I go, you know, there's my cold. I will get the cold for myself. Clinical manifestations, rhinitis, which is the inflammation of the nasal mucosa. Secretions, right? Secretions that they are watery and clear. This is what I told you. You know, if after 10 days you are not getting better, you are getting worse, the nasal secretions went from being clear to being super purulent and green and bad, then it's maybe when you are going to be needing an antibiotic, not before, okay? Postnasal drip. Sometimes this drip that goes from postnasal area, sometimes it can cause cough, and also it may cause throat sore, okay? So maybe some people may think that they have a strep throat, and what they have is a postnasal drip that is causing this sore in their throat. And as I said before, the treatment, rest, decongestants if they need them, and if they have fever, they can also take antibiotic drugs, okay? That's for the common cold. Moving into sinusitis or rhinosinusitis, this will be inflammation of the nasal mucosa, and when we talk about sinusitis, we are going to talk about inflammation in the paranasal sinuses, okay? What are those sinuses? Those are openings, let's go here, narrow openings. They are in our skull, right? And we have 2 maxillary sinuses. Let's go to this one. 2 maxillary sinuses here, 2 frontal sinuses, and then we have 2 pairs of ethmoid sinuses, and behind we have the sphenoid sinuses, okay? Those can be filled up with, I'm going back now, this can be filled up with mucus, and it can be really, really painful sometimes for some people. So let's see the difference between rhinitis and sinusitis. Most of the people will have both, okay, and this is what is called rhinosinusitis. Sometimes we refer to sinusitis, but actually what the patient is having is rhinosinusitis, so both. The rhinitis, which is the inflammation of the nasal mucosa, in this case, the rhinitis is not going to cause any thick mucus in the sinuses. Only the sinusitis will cause purulent mucus in the sinuses. You see, purulent, and then purulent discharge from the nose, okay? On the opposite side, it will have rhinitis, we will have a clear watery discharge. So, to review this, to make this a little bit more clear, we can have rhinitis if only the nasal mucus is infected or inflamed. We can have sinusitis if only those paranasal sinuses are inflamed, or we can have both, and in this case will be rhinosinusitis. Most of the times is rhinosinusitis what patients have, and sometimes we just call them sinusitis. But I just want you to be able to see the difference in, in theory, okay? This is what in the book says, but in practice what we see is always, most of the time, rhinosinusitis. Everything is inflamed. So these are the definitions of the different sinuses and where are they located. Again, this is a picture that shows more clearly where they are. And we can classify the rhinosinusitis depending on the time of the infection or inflammation. Acute will be when we have less than a month. Subacute, when we go from 1 month to 3 months, more or less. And chronic, some people have chronic rhinosinusitis, and it's when it lasts more than 3 months. Diagnosis usually is just by physical examination, and one thing that the patients usually complain is about pain in the face, pain in the head, and it gets worse when the patient bends over, when he's trying to tie the shoes, and then it's like even more pain, okay? Or when they are coughing, or when they are sneezing, even the pain is even worse on those situations. In severe cases, when the inflammation doesn't go away, the patient may have MRI or a CT scan in order to see if something else is going on with that area. And the treatment, as I said before, depends, if it's caused by viruses, just rest and fluids, and it will go away by its own. But if we have an infection with bacteria, then we will need antibiotics, and the treatment is usually 7 to 14 days, depends on the antibiotic. And important to tell them, the people, right, that you have to take the medication for the time that the prescriber tells you, because if you stop taking the medication because you are feeling better, those bacteria that are in your body are going to become resistant to that antibiotic, and it's when the problem becomes a major problem, okay? We don't want any more bacteria resistance to antibiotics. It's a major problem nowadays in our society. Let's move into influenza, the flu, right? Influenza, flu. Big news this year, right? Big news this year because it's really, really aggressive. The influenza this year, the virus is it's being very, very aggressive. The people that get influenza this year, it lasts at least 2-3 weeks, and people are really, really with bad symptoms this year. And another thing that is happening this year is that the vaccination that we all get is not covering for the virus this year. Not covering very well. So it's covering only, like I heard, I think it's 20-30%, no more than that. So there is a big chance that even if you got vaccinated vaccinated against the flu, still we may get the flu, unfortunately. There are different types of influenza. We have type 1 and type 2, which are them. Okay. Let's go back to the previous slide. Let me see. Highest mortality in children and adults. This means that older adults.
Older adults, okay.
Yes, older adults. This means that children, if they get the influenza, or the older adults, if they get the flu, is the ones that are at higher risk of having complications and even dying from the influenza. Okay? Let's put here. Older adults or elderly, right? Okay. So types of influenza, we have type 1 and type 2. Actually, there are also type C, type D. There are other types of influenza, but A and B are the most common. When we are tested, if we suspect that we have influenza, we can go to the provider and they can do that swab in the nose, right? And they can check if you have influenza or no. It will be checking only for A and B, okay? I mean, C and D are very, very uncommon, but it will check for A and B. The thing is that, it really doesn't matter which type you have, the treatment is going to be the same. Fluids, rest, medication for fever, if you have fever, right? Antipyretics, and that's it. They're not going to give that much. Let's talk about some medications that they can give you if you have the flu, but only if you have less than 48 hours of symptoms. So you go to the prescriber, right? To the healthcare prescriber, and then you say, okay, I had the flu for 2 days. I mean, I started maybe 30 hours ago, I started feeling the symptoms. Okay, they are able to give you these medications against the flu, okay? These antiviral medications. However, if you go and say that you started feeling the symptoms more than 48 hours ago, they will not give you this medication because it will not work. So you will be taking medication and then the thing will not work. The thing with this medication is that it's not going to cure anybody from the flu. What it's going to do is to shorten the time of the flu. So instead of having 10 days, the flu, you may end up having the flu for 8 days. So it will shorten the flu for 2 days, no more. So you start taking the medication today, and then you started having the flu yesterday. So yesterday was Tuesday, so you may have the flu still until next Tuesday. So the only thing it's going to do is to shorten the time of the flu by 2 days, more or less. You know, it depends. You know, people behave differently with different medications, but in general, that's the general situation. Some people actually say that the side effects for these antiviral drugs were worse than feeling the flu, and they stopped taking them. So, you know, and other people love them. Other people say, okay, yes, I want that because last time I had the flu, it helped me a lot. So it depends on the person. Let's move into acute bronchitis. There is only this slide for acute bronchitis, and I put it here because later on we are going to be talking about chronic bronchitis, which is different, but I wanted you to have a definition of the acute bronchitis. Usually it's also viral, and it's going to affect the airways or bronchi, right, or the respiratory system. It's going to be an infection that can cause inflammation. Sometimes the symptoms are going to be similar to those of pneumonia, but we are going to see how pneumonia is going to be assessed, and we are going to see that there are going to be ways to distinguish between acute bronchitis and pneumonia, okay? Just as an introduction, with pneumonia, we are going to see something that is called lung consolidation, that we don't see it in acute bronchitis. Later on, we are going to learn what acute lung consolidation is, so let's leave it for the next disease, which is pneumonia, okay? Here, pneumonia. Pneumonia is an infection of the lower respiratory tract. Very careful with elderly that have pneumonia. With the elderly, sometimes, you know, we see that they have altered mental status. It's like they are confused, totally confused. And what's happening with them? They may have an infection. They can have a pneumonia or either UTI, urinary tract infection. So those two are main reasons for the elderly to have an confusion. So pneumonia can be caused by a microorganism, but also it can be caused by a non-infectious agent. So with infectious agents, we can have bacteria, viruses, fungi, parasites. Many things can cause pneumonia. The most common one is going to be bacteria, but let's look at that later. But also I want to remark that people can get pneumonia with non-infectious agents. So aspiration, right? Aspiration can cause pneumonia. This is one of the reasons why patients, when they are going to go into surgery, they are NPO, which means nothing per mouth, right? And nothing orally, no water, no fluids, no food for at least 8 hours, right? Or from the night before. So the night before, if the person is going to have surgery today, from last night at midnight, they should stop drinking, they should stop eating. Why? Because there is a risk that the person is in surgery, and the food that is in the stomach content, can go up and then go back to the respiratory system and then cause pneumonia in that patient. So that's why sometimes they will refuse to do surgery on you if they ask you when it was last time that you eat, and you say, okay, I ate 4 hours ago. Okay, so you probably will be canceled for surgery for another day because they don't want to take the risk, okay? They don't want to take the risk. So there are different ways to classify pneumonias. We have what is called community-acquired pneumonia, and we have hospital-acquired pneumonia, which is also called nosocomial pneumonia, okay? Another way to classify the pneumonias would be typical and atypical, and also we can classify pneumonias by where in the lungs the infection happens. When we are talking about community-acquired pneumonia, this means that the pneumonia has been acquired in the community. So if there is a patient that is going to be admitted in the hospital, right? And then that patient, after 24 hours of being in the hospital, the patient starts having signs and symptoms of pneumonia. So that pneumonia was actually acquired, not in the hospital where the patient is now, but in the community, okay? So in order to classify those as community-acquired pneumonia or hospital-acquired pneumonia, we have to see when the symptoms start. If the symptoms start when the patient has been just admitted, less than 48 hours of being in the hospital, that will be community-acquired pneumonia. If the symptoms start after 48 hours of the patient being in the hospital, that will be hospital-acquired pneumonia. When we are talking about that, also we can think about if the patient is coming from a nursing home, okay? The same, okay? The same classification. So, and then microorganisms microorganisms, the most common one that is going to be causing community-acquired pneumonia would be Streptococcus pneumonia. Sometimes this pneumonia will be pneumococcal pneumonia.
Those classifications are regardless of bacterial or infectious or non-infectious, right?
This is infectious. Yes, infectious, because this is caused by a microorganism. Yes.
No, I'm talking about the ones before where you're classifying it based on if they've had the symptoms less than 48 hours.
That's also with microorganisms, because if it's aspiration pneumonia, that happens in the moment. Okay, so it's very clear when that may have happened, because it's not something that gets like you know that something has happened. The patient has been starting choking, and you can see that aspiration pneumonia has happened. So, and if they are in surgery, you know that this has happened as well. So the classification about a community-acquired pneumonia and hospital-acquired pneummonia, we usually apply for microorganisms. So bacteria, viruses, mycoplasms. So any of those ones is when we talk about community-acquired and hospital-acquired. That classification about aspiration pneumonia or no microorganism pneumonia, it's just so you can see that there are other causes of pneumonia, because there are some people that have pneumonia that has nothing to do with microorganisms, but with aspiration or with something else going on in the lungs. So as I said before, the most common one is the Streptococcus pneumonia. That's the most common pneumonia in the community-acquired pneumonia. We have other ones, Moxarella catarrhalis, Haemophilus influenza, Legionella, sometimes it's on the news, right? The Legionella, so that's also important. Mycoplasma pneumonia. Okay. This is the definition of the hospital-acquired pneumonia when it's diagnosed more than 48 hours after the admission, and the mortality rate is much higher than the community-acquired pneumonia. Then we have a pneumonia that is very prevalent in people that are immunosuppressed. For example, people with AIDS, right? People with AIDS are prone to opportunistic infections, and this is going to be one of those opportunistic infections. Next week, if we have time, at the end of the chapter next week, we will talk about HIV, and then we will talk about opportunistic infections, and we will be able to see how pneumonia, this specific pneumonia, the one that is pneumocystis jirovecii pneumonia, that specific one will be an opportunistic infection for people with AIDS, okay? Then let's look into the difference between typical pneumonia and atypical pneumonia. So typical pneumonia is the pneumonia that we all know. The person is infected, the person has pneumonia, the person is in bed because he's super tired, super sick, with signs and symptoms of pneumonia. Atypical pneumonia is caused by a different microorganism. It's caused by this Mycoplasma pneumonia. And it's called walking pneumonia because the person may feel not good, right? Not perfectly good, but still good enough to go and do still all the things that the person has to go and, go to class, go shopping, go to the supermarket. So still the person is able to get out of the bed and do their things. So they have like different signs and symptoms. And the thing is that it's caused by a totally different organism. I'm going back to talk about the typical. So with these people, right, they have severe fever, chills, malaise. And in the X-ray, we will be able to see what is called a lung consolidation. Lung consolidation. That would be, are you familiar with X-rays in the lungs? So that would be like a very white patch in the lung. That would be called lung consolidation, okay? Lung consolidation. We are going to see what is causing that lung consolidation. That's happening again in typical pneumonia. That pneumonia that is going to be very more aggressive, the person is going to be feeling much worse than with the atypical pneumonia or walking pneumonia. Here, with this atypical pneumonia, we are not going to see lung consolidation. So there is a lack of lung consolidation. What we are going to see is a patchy involvement of the lungs. So instead of being that white area that we see with typical pneumonia with lung consolidation, we will see something more diffuse, more like some whitish thing, but not so clear, okay? And this is caused by the following. So in typical pneumonia, when we see lung consolidation, there is going to be fluid going into the alveoli, right? So these are the alveoli of the lungs, right? Remember, the alveoli are those little sacs in which we are going to do the exchange of gas, right? We are going to exchange the gas in the alveoli. So those alveoli are going to be filled with fluid and with white cells, right? White cells, you see, they are all inside of those little sacs. However, in atypical pneumonia, in which we will see a patchy involvement of the lungs if we do an X-ray. You see, in this case, all those alveoli are all clear and open. You see? The only thing that we see is here, between the alveoli is where we see that something is going on. That is going to give us the patchy involvement in the X-rays.
What did you say all that stuff was inside of the alveoli in the typical one? White blood cells, what else?
There is fluid and exudate and white cells and debris. That is, all this is making these alveoli fill, and they are going to be unable to do the gas exchange. This next slide also is going to help us to distinguish between typical and atypical pneumonia. Again, the atypical pneumonia is the walking pneumonia. Typical is the one that the person is feeling really bad with fever, chills, productive cough, pleuritic pain. With this atypical, it's just a little bit of malaise, some dyspnea, some dry cough, some headache, but still the person is able to continue with their life. Important to remember also are the bacteria that are causing these typical and atypical pneumonia. With typical would be the pneumococcal, and with atypical would be the mycoplasma. And on examination also is going to be different. Why? Because with one of the things that is going to be really important to distinguish them is the lung consolidation, right? So with typical, we will have lung consolidation, which we don't have it with the atypical. That lung consolidation is going to give us one way to distinguish both of them without doing an X-ray. How? I don't know if you're familiar with the physical examination of the respiratory system, but what we usually do is we do percussion, we auscultate the lungs, right? And then we also do what is called tactile fremitus. So we ask the patient to say 99, 99, and then we go in both sides of the lungs, and then we feel in tactile fremitus how the lungs are vibrating. When we have lung consolidation, we are going to have higher tactile fremitus, okay, with lung consolidation. So when we are auscultating and then we are listening to the lungs and we are asking the patient to say 99, for example, we will hear that usually in a normal lung, we will hear very distant and muffled sounds. However, if we have lung consolidations, those sounds are going to be much more clear. Those sounds are going to be transmitted much better to my stethoscope, okay? So if I ask the patient to say 99, I'm going to start listening like this. 99, 99, 99, and then suddenly I will hear 99, super clear when there is lung consolidation. Okay, the sound is going to be transmitted better, the fremitus is going to be transmitted better. Another way, that would be called, let me show you later, it's called bronchophony, when I tell you about the 99, okay, that's called bronchophony. Echophony will be the same thing, okay, echophony will be the same kind of thing. We are asking the patient to see E, and then when there is consolidation, we are going to hear it as an A, okay? And then we have also another way to check it, that is telling the patient to whisper 1, 2, 3, bless you. So if they whisper 1, 2, 3, so they will be whispering, and so that I will not hear anything while the patient is whispering 1, 2, 3. But suddenly I reach the point of the lung consolidation, and I will hear a 1, 2, 3 very clear. So I will hear nothing, 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 and then 1, 2, 3 very clearly, because the sound is transmitted super clearly through that lung consolidation. I'm moving in a ladder way. I'm listening both sides at the same time. So I'm comparing the right one against the left one, okay? And I'm going point by point, okay? Okay, so that's the physical exploration of the patient. So you can see if we have lung consolidation, all those positive findings, I'm not going to find them in atypical pneumonia because we don't have lung consolidation. So let's keep going to the next slide. This is the same thing. We have, this would be for typical pneumonia. That would be for typical pneumonia, infection and inflammation, and then we have the exudate that is going to go inside of those alveoli, and then we have a productive cough. Okay, productive cough is when we have some phlegm. Okay, so manifestations for both of them is going to be some fever, headache, malaise. Sometimes we can have nausea and vomiting, cyanosis sometimes, change in sensorium. This means confusion, right? Mostly in the elderly. Productive cough in typical, because the atypical has very dry cough. Sometimes it's caused with an upper respiratory infection that goes down and causes pneumonia. So the patient will start telling you, or telling the person, I had a cold like 2 weeks ago, and suddenly I'm like this, I'm like so much worse. So it may go from being a cold or an upper respiratory infection to being pneumonia. And this is the assessment of the typical that I was telling you, that because we have lung consolidation, we are going to be having those positive symptoms. So dullness on percussion. So we can percuss the lung, and then we will feel dullness, okay? In a normal lung, we will hear resonant. But with dullness, with lung consolidation, we will percuse dullness. With palpation, we can feel like there is an increase of the tactile parameters. With auscultation, we can hear how this whisper test, whisper pectoraloquy, the one I was telling you about 1, 2, 3, 1, 2, 3, that if the patient whisper, I shouldn't hear it through the stethoscope. However, if I have a patient with consolidation, I will hear very clear 1, 2, 3, even though the patient is whispering. The echophony, the person says E, and bronchophony is when I hear muffled sounds like 99, 99, 99, 99, super clear, okay? That's bronchophony. Diagnosis, we may probably need some cultures on those patients with pneumonia in order to see which bacteria or microorganism is causing that disease. Any questions about pneumonia? No? Yeah, just pass the last two ones. There is not much to see in the last two slides. Yes? Tuberculosis. So tuberculosis. It's an infection with Mycobacterium tuberculosis. It's a bacteria, it's a Mycobacterium, okay, that it will infect the lungs. But also, I mean, I don't know if you're familiar with tuberculosis, but you know, most of us, we know about tuberculosis infecting the lungs, but the tuberculosis actually can infect, the bacteria can infect any of the other organs in the body, many of the other organs. And in that case, we will have what is called disseminated tuberculosis or miliary tuberculosis. It's the same, okay? That happens when it goes from the lungs to other parts of the body, like to the brain, to the GU system, to the bones. So that bacteria can go to many different parts of the body and not staying in the lungs only. Okay, that's when it's called disseminated tuberculosis or miliary tuberculosis. Yes.
Are there still cases of tuberculosis?
Yes, yes. We have still cases. Unfortunately, too many. Many more than what we wish. Yes, in the hospital, we have patients with tuberculosis. They are in special rooms. They have to be in a room with a negative pressure because when we open the room, we want everything to go inside of the room. All the air should go inside of the room, right? We don't want those microorganisms to go outside to the halls where everybody's walking, right? So the patient will be in a special room with negative pressure. So when you open the door, the air goes inside of the room. The person that goes inside of the room has to be fitted for an N95 mask. Those masks are special for airborne droplets. That's how we get tuberculosis. So the person is talking to you, airborne droplets are around, and then you breathe them in, and then you get infected. So that's why we want all those droplets to stay in the room. That's why the patient is in a negative pressure room, okay? Every time that someone goes in, has to go with an N95. Nurses are fit for N95 masks because that has to, I mean, it has to be very well fitted. It has to be the perfect one for you because if there is a very small hole in that mask where those droplets go in, you get infected, okay?
But why is it still around?
So it's still around because one of the, okay, it was let's go back, and you know I never asked you about numbers, right? But in the 80s, from the 50s to the 80s, there was a huge decline of the number of tuberculosis because the treatment was effective. However, after the 80s, the number started going up because tuberculosis is also one of those opportunistic infections for people with HIV. And remember that from the 80s to the 90s, then people with AIDS increased a lot. So all those people go tuberculosis. Again, the numbers are going down again, because we have nice antibiotics that are treating those mycobacteria. However, the treatment is very long, as we are going to see. It's like 6 months, 9 months of treatment with antibiotics, with 4 antibiotics some of those months. So some people actually don't do the treatment. If they don't do the treatment, they still will have those mycobacteria inside them, and they can wake up. We are going to see how TB works, but they can wake up again. Or, you know, they become resistant to those antibiotics. So it's a major problem. Also, there are many of those patients with tuberculosis, they are homeless. And they don't care about antibiotics. They don't care if I'm talking to you and I give you the tuberculosis. So actually, there is a tuberculosis has to be followed. So there is a program where they will go to each of the person that has tuberculosis to make sure that they are being treated and they are following the treatment. You know, so it's really, really important to follow the treatment because it's very contagious.
So how do they do that with homeless people?
With homeless people, they usually go sometimes to home, how it is called? Shelters, and they have people there that they are informed about people that have tuberculosis, and they will actually try to follow with them.
Like who pays for the medication?
So let's go here. So this is what we usually put in the rooms of the patients with tuberculosis. Airborne precautions. So if anybody goes to that room, they have to talk first to the nurse, okay? And again, there is the door should be always closed. The air should be in a negative pressure room. The patient, when it's transported, the patient should wear a mask, a surgical mask, a normal mask, okay? And everybody that goes inside of that room should be wearing an N95 to protect from those airborne droplets. So this is, usually what we have in those rooms with people with tuberculosis. And then I'm going to explain you what's happening with tuberculosis, okay? So I'm talking with one of those patients without wearing my N95, and then suddenly I'm going to inhale those microbacteria, right? So it's going to go to my lungs. So usually when we get bacteria into our lungs, macrophages are going to come and ingest them, and they are going to phagocyte those bacteria, and they are going to kill them. With Mycobacterium tuberculosis, however, this doesn't happen. Those macrophages are going to eat those Mycobacterium tuberculosis, but instead of killing them, those Mycobacterium tuberculosis are going to start replicating. So they are going to start growing, and then this is going to elicit immune response. So other immune cells are going to come to the area. And then at the end, we will have an area of the lung that is full of dead tissue with macrophages that are ingesting that Mycobacterium tuberculosis, and then other lymphocytes surrounding that area. That's what is called granuloma. There are granulomas in different diseases, like also we have granulomas in Crohn's disease. But when we are talking about tuberculosis, that granuloma is going to be called gone focus. Again, gone focus or granuloma is nothing else than macrophages that phagocyte the microorganism, and they are surrounded by some lymphocytes and other immune cells, and then the tissue inside of that area is actually dead. That's the granuloma. When that granuloma includes lymph nodes, we call it gone complex. Okay? So that happened to me. I breathe in the microorganism, then the macrophages are going to go to that area to ingest that microorganism, but that microorganism is not going to die. It's going to be replicating and making more and more microorganisms. All that tissue is going to be also surrounded by other immune cells like lymphocytes, and it's going to be dying. That tissue will die. That's what is called the granuloma. Okay? Those granulomas can be there forever in my lungs. That will be called a healed dormant lesions. They can be there for all my life. All my life, I will not know. I will know if I take my PPD test. I will see that the PPD is positive because I had an infection. I had some interaction with that microorganism. But otherwise, I will not know. So I will have a positive PPD, right? If I have the granuloma, but I will not have signs and symptoms. I will not feel anything. I will not feel that anything is happening to me. Okay? I will be okay. However, I have those granulomas, that dormant lesion there, and then, for whatever reason, my immune system next year goes down. Those microorganisms are going to wake up, and they are going to start infecting more and more of my lung. We are going to have what is called reactivated tuberculosis. Okay? And then now I have all these signs and symptoms of tuberculosis. I'm losing weight. I have sweats at night. I'm sweating at night a lot. I have cough, sputum with blood. I am like, something is really bad with me. I have low-grade fever. Okay? Now I have tuberculosis. It's called secondary tuberculosis. The other one that I was not feeling anything, that I just had the granulomas, was the primary tuberculosis. Okay? That I'm telling you about me, that I have a nice immune system right now. But however, if that primary tuberculosis happens in a patient with a low immune system, with an immune system that is low, like in AIDS patients, right, with an immunocompromised state, it will go directly to being an infection, right? Directly will be an infection, and they will have the signs and symptoms. One thing also that is important to remember is that with this healed dormant lesion, okay, I don't have signs and symptoms, right, as I told you before, and also I am not going to infect anybody, okay? I'm not going to infect anybody. I'm not contagious, okay?
But once it reactivates, then you become contagious.
Once that it reactivates and I start having all these signs and symptoms, yes, I'm contagious. So let me tell you a little bit the percentages of this disease. Let me go here and erase this because I want to tell you about the percentage here. So I have my granuloma, right? I went into one of those rooms without the N95 and I got the infection. I have the granulomas and I have a healed dormant lesion. So in 95% of the cases, when you get infected, the lesion is going to be dormant. In 5% of the cases, they will have infection. because they have a low immune system or whatever reason, okay? So 5%, yes, they will go directly to have tuberculosis. But in 95% of the cases, no, we will have a dormant lesion, okay? And from that dormant lesion, about 5% of the people will get reactivated. Any questions?
So this left side, the entire left side, doesn't have any signs or symptoms.
We don't have any signs and symptoms in this side, no signs and
You only
symptoms.
see signs and symptoms when you have secondary tuberculosis.
We only have signs and symptoms when we have, in this case, it's called secondary tuberculosis, yes. And only you are contagious when you have signs and symptoms. Remember also, sometimes you have a positive PPD, you are not contagious. You know, you are not contagious. Still, you may have contact with someone that has tuberculosis and you have your granulomas in your lungs.
Just the granuloma, is that going to be a positive PPD or
Yes, just
it's a complex?
just with the granuloma, with the gone focus, you will have a positive PPD. Yes, yes, yes. So this is again what I just told you. Primary TB usually is the gone focus or the granuloma, right? And then the bacteria are inactive in these cases, and they are not contagious, and they have a positive PPD, right? However, if this granuloma or gone focus happens in an immunocompromised person, we will have progressive TB or secondary TB, which will show signs and symptoms and is contagious as well, okay? So gone focus, again, this is what I told you about. And then again, primary and secondary tuberculosis, what I was telling you about. And then the signs and symptoms, again, low-grade fever, night sweats, anorexia and weight loss, hemoptysis. This means that they are coughing up blood, okay? And dyspnea. Dyspnea is the dyspnea short of breath, right? Dyspnea is short of breath, so we have these symptoms. Again, the same kind of symptoms, just in case that you are going to understand them better with pictures. And let's talk a little bit about the TB screening, or PPD, right? Since we have it done, we want to understand a little bit more about this test. When they are, they are going to inject TST intradermal, right? It's a protein derivative of the bacteria, and after 48 hours, they are going to check how that injection is. What they have to check is not that it's red. It doesn't matter if you have the whole arm red. That's not what is important. What is important to check is the induration. Induration, okay? So when you go and have your PPD check, they should be checking not with their eyes, but with their fingers, checking if there is an induration, okay? Induration.
So induration is the raised part?
Yes, induration is like there is a bump. Exactly. It doesn't matter if it's red, it's if there is a bump, okay? And then we have usually in normal population, if the induration is more than, let's go to this one, more than 15 millimeters is when it's going to be positive, okay? However, there are different values for other people. For example, people that are immigrants in the last 5 years, or IV drug users, or people that are working in jails, in nursing homes, in hospitals. So those people, if they have an induration that is larger than 10 millimeters, will be positive. So me, I am a nurse, I work in the hospital, I go and have my PPD done, and I have an induration of 12 millimeters. That would be positive, okay? However, my friend, she is a lawyer, and she doesn't have to do anything with the hospital, and she's not an immigrant, and so she will have an induration of 12 millimeters. That would be negative for her, okay? Again, okay, another value, more than 5 millimeters for people that are HIV positive, for people that have organ transplants, for people that are having recent contact with a TB positive individual. So my friend, her husband had TB last month, and she, my friend, she went to have a PPD done, and her induration was 7 millimeters. If I have 7 millimeters induration, that's negative for me. But for her, that she is living with her husband who has tuberculosis, that would be positive. Okay? How do we diagnose tuberculosis? So we cannot diagnose tuberculosis with a positive PPD. That's just one way to screen, okay? The way to diagnose tuberculosis would be with cultures. Cultures of the blood, cultures of the sputum. So remember, I don't know if you ever had a positive PPD, but usually when a person has a positive PPD, what they do, the next step would be to do a chest X-ray. And what they are going to see in those chest X-ray, they are going to see cavitations that are caused by those granulomas. Cavitations in the lungs. But the way to diagnose a person with TB would be cultures. They have to culture to make sure that that microorganism is in the body of that person. And the treatment, there are 4 different antibiotics used for the treatment of TB. These are the 4 different antibiotics. If a person has a positive PPD and they do a chest X-ray and they see that actually there are cavitations and there is some granulomas there in their lungs, they actually they put this person on antibiotics for about 6 months. They will put the person in isoniazid for 6 months. Okay, if it's a latent tuberculosis, they want to make sure that those latent microorganisms that they are going to die. Okay. However, if we have a active TB, they will be also 6 months. I mean, from 6 months to 9 months. Maybe your farm book is a little bit different. I don't know exactly what your farm book, but if you are going to be asked those questions in farm, answer with your farm book. Okay, it's from 6 to 9 months, and the treatment is with 4 antibiotics. Those 4 antibiotics for 2 months, and then the rest of the treatment, the 4 or the 6 more months that they have to keep going with the treatment, they will drop these 2, and they will continue with NIH and rifampicin. Okay. They are changing the way that they are treating people. The reason why they give those 4 different antibiotics is to avoid resistance. Okay, this way they don't have bacteria that become resistant to those drugs, which is really important at this point. And this is a summary of what I told you about tuberculosis so far. So let's talk a little bit about ventilation and perfusion if you don't have any more questions. Okay. Ventilation is the movement of air into the alveoli, right? The movement of air into alveoli, and we are going to get the oxygen and we are going to release the CO2. And perfusion is when the blood reaches the capillaries of the alveoli. Let's look at some alveoli here. Remember, this is how the lung is made of, right? We have the lung here, we have the different airways, and then at the end of those airways we have those alveoli, right? Remember them? So remember, around the alveoli we have pulmonary capillaries that are going to help us with the perfusion of the lungs. And the way that this happens, remember the alveoli, and then we have the capillaries here, and here we have the alveoli. The CO2 and the oxygen go in and out, and then again we want oxygen going in and CO2 going out. That's what it would be called. I mean, perfusion is here, but then we have an exchange of gases here, okay, at that area. That's where the exchange of gases happen. So usually the way that the oxygen travels through the body is dissolved in the blood, right? How? The oxygen is going to be in the hemoglobin, right? In the hemoglobin, right? And then it's going to be called oxyhemoglobin. CO2 also is going to be traveling through the blood, right? Because the CO2 has to go, and it's going to be going from every cell in the body, and it has to go all the way to the lungs, where we will release the CO2 outside to the atmosphere. And also that CO2 can be bound to hemoglobin. In this case, it will be called carbaminohemoglobin. 10% of the CO2 will be traveled in this way. Most of the CO2 will be traveling in the way of by car, and a little bit, like 5-7%, will be traveled also in the way of free CO2. So that CO2 that is in the blood is going to be sensed by our body, okay? How do we sense that CO2? We sense it with sensors. We have chemosensors. We have some sensors in the medulla, in the brain, right, that they are going to sense the amount of CO2. Actually, it will be sensing also the pH. Remember, the higher the CO2, the more acidic the pH. So if I have a lot of CO2 in my blood, my sensors in my brain are going to increase the respiratory rate. If I have a pH that is basic, my sensors in my brain are going to decrease my respiratory rate. So I will be retaining a little bit more of CO2 to compensate and then be at the right pH. Also, there are some receptors in the lung. So those receptors that I was talking about, they are the central chemoreceptors that are in the brain stem, right? And they will increase or decrease the respiratory rate depending on the pH of the fluids in the body. And also we have peripheral chemoreceptors in the carotid and the aortic bodies. And again, they are going to be measuring the CO2, but they also, those peripheral ones, they also will measure the amount of oxygen. So most of the time, our body is going to be sensing how much CO2 we have in our body, and that's what's going to make our body to increase or decrease the respiratory rate and the depth of breath to compensate and then have a balanced pH. Remember, pH from 7.35 to 7.45. If we go up or down, the CO2 is going to be regulated by these central chemoreceptors. For people with COPD, however, what is going to be changing the rate of respiration is not going to be the CO2, because usually they are going to retain a lot of CO2. So what is going to be changing the rate of the respiration is going to be the amount of oxygen that they have in the body. That's why when we are talking about giving oxygen to patients with COPD, we are going to talk about COPD in a second, but when we are going to give oxygen to people with COPD, we have to be very careful because the drive of the respiration is going to be set by the amount of oxygen. And if we are going to give a lot of oxygen to those COPD patients, they are going to decrease the rate of respiration, and they may have such a low respiratory rate that they may decompensate very, very, very quickly. Okay? I'll continue. Pulmonary circulation is going to facilitate the gas exchange. And we have here two of those definitions that we already know. We know what hypoxemia is, and we know what hypercapnia is, right? So we already seen those definitions before. So we are talking about one way to compensate the amount of CO2 in the body, right? However, there are people that have problems with the brain, right? With the brain. So if we have a central nervous system disorder or they have a spinal cord dysfunction, they are not going to be able to regulate that respiratory rate that well, okay? Also, if we have people with problems in their chest, right? They have probably a neuromuscular disease, or they can have a problem with the chest wall, or some pulmonary dysfunction. This is why. They will have a decreased ability to ventilate, which will have a lower tidal volume, and all of this is going to cause acidosis, right? We are familiar with that. We are going to retain a lot of CO2, which is hypercapnia, which will cause to lower the pH, and also we will have a decreased amount of hypoxemia. In that case, we should be careful because the person can end up having dysrhythmias, coma, and actually die. Okay? Perfusion and ventilation mismatch. This is, again, an alveoli. This is how normally we have the ventilation perfusion. So normal ventilation will be the amount of air that is coming in. Perfusion will be the blood that is coming through the capillaries, okay? So this will happen in a normal one. We will have CO2 coming out from the capillaries all the way out through the exterior of the body, and the oxygen has to go into the blood and then continue and oxygenating all the cells in the body, okay? However, sometimes our alveoli is blocked. However, you know, in this case, we have, for example, if we have all our alveoli full of a fluid, we are going to have a problem, you know? Our perfusion is going to be okay, but because the ventilation is all blocked, we will not have oxygenated blood going to the body, okay? That's what is called shunt, okay? In other cases, the problem is here. The problem is in the capillaries, that they are all blockage. We have very nice lungs that are able to bring air in and out, so they will bring oxygen in and leave the CO2 out, but because we don't have perfusion in this case, we are not going to have an exchange of gases, okay? So that's called dead space. Can you think about any example when we see a dead space because we are blocking the capillaries? Huh? Pulmonary embolism, yes. Pulmonary embolism, PE. Pulmonary embolism, right? There is an emboli that is going from my DVT, an embolus is going to go all the way to my lungs and it's going to block that capillary. So my lungs are working perfectly. I can breathe in and out, but the exchange of gas is not happening because my circulatory system is all blocked. So even though I'm breathing in and out, there is not exchange of gases, I'm going to die. Okay? And the fourth case here, we have both problems. We have a blockage here in the capillaries, and also we have a problem with the respiratory system. In this case, it's called silent. Okay? These are examples of ventilation and perfusion mismatch. So we have to make sure that everybody has the right perfusion and the right ventilation. Yes.
For both of these, the alveolus is blocked?
Yes. Are you talking to me?
Yeah, you said the alveolus. What is the normal for at the top of the left one?
The normal one is this one? A, B, C, D, yes. So let me... So yeah, we just saw 4 different cases of 4 different situations. Okay? Okay. So pleura. Remember the pleura? Pleura is that sac that is recovering the lungs, right? They are recovering the lungs. And we have like the same thing that we saw with the cardiac pericardium, right? We have a sac covering the heart. The same. We have here a sac covering the lungs. And they also have 2 layers, the visceral pleura and the parietal pleura. And between both of them, we have the space, pleural space between both of them. The same concept that with the cardiac pericardium, okay? So in that space, we can accumulate different things. we can accumulate fluids, we can accumulate air. Nothing is good. We don't want to accumulate anything in that space. So if we accumulate fluid in that pleural space, that can be called pleural effusion. And there are different kinds of pleural effusions depending on the kind of fluid that we are accumulating in that area. We can have clear fluid. In that case, would be a transudate. That happens probably most of the time with people with heart failure. Remember heart failure? We are backing up the blood from the left side all the way to the lungs. So then there we are going to be accumulating fluid in the pleura. We have too much fluid there, and it will be just clear fluid. Exudate fluid is when we have a fluid rich in proteins and WBCs. Empyema is when we have a fluid that is full of pus. Chylothorax is when we have a fluid accumulating there that is full with chylomicrons. And hemothorax is when the fluid that is accumulated in the pleural cavity is blood. Every time that we are accumulating something in that pleural space, we are going to have pain. Characteristics of this pain is a sudden onset of the pain, usually is unilateral, and usually is made worse with chest movements. So if we are breathing in and out, that pain will be worse. Diagnosis of the pleural effusion usually is done with a CT scan, with sometimes with ultrasound or chest X-ray. And the treatment, we can remove the fluid with a needle. That's what thoracentesis is. We put a needle in, we remove the fluid. That's thoracentesis. Sometimes we need to insert a chest tube to drain all the fluid in that area. So in addition to fluids in that pleural space, we can also accumulate air. In some cases, it's just air. In that case, we call it pneumothorax, okay? So air or gas in the pleural space. So as you can see here, if we have air or gas in that pleural space, we are going to collapse some of the lung, okay? There are different types of pneumothoraxes. We have what is called spontaneous. Sometimes they happen for no reason. Usually it's happening in people that are young, healthy people, and sometimes tall. That's what they say. Tall, young, healthy people, suddenly they go to the hospital with shortness of breath, and they find that they have pneumothorax for no other reason than, no reason. But other cases, we know the cause, and sometimes this is because there is a trauma, right? Car accidents, stabs, bullets, anything can be causing this pneumothorax. Another way to classify this pneumothorax would be by open pneumothorax or tension pneumothorax. Let's go to the next slide where I have an example of open and tension pneumothorax. Open would be just, you see here the air going inside of the pleural space with no problem, and then the air also leaves the pleural space with no problem. So you see there is air coming in and out. Okay, however, with the tension pneumothorax, the air can go in, however, there is a resistance for the air to leave. Okay, those are more complicated than the open pneumothorax. The tension pneumothorax can give us more problem. One of the problems that it's going to give us is that we are going to have what is called tracheal deviation. Tracheal deviation. So you see, the trachea is going to be deviated towards the opposite side. So we have a right tension pneumothorax. The trachea is going to be deviating towards the left. Okay, towards the left. One of the things that is going to happen with this pneumothorax is that we are going to have what is called decreased breath sounds. So the breath sounds that we normally hear in a person when we are auscultating the lungs, they are going to be decreased. We are going to hear also hyperresonance. Hyperresonance, remember, with percussion, we can hear resonance, dullness, or hyperresonance. With lung consolidation, remember, we were seeing dullness. We were hearing dullness. With pneumothorax, because it's full of air, we are going to hear what is called hyperresonance. Hyperresonance. So let's go here. So you see this is a tension pneumothorax, okay? So we are going to have the tracheal deviation, which is really important, against the opposite side. We are going to have decreased breath sounds. We are going to have hyperresonance on percussion. We are going to have, to put a needle or a chest tube or a needle. So chest tube or a needle to treat that tension pneumothorax. Okay. Again, clinical manifestations: pain, of course. This is in general for pneumothorax. So it will be shortness of breath, dyspnea, tachypnea, decreased breath sounds, hyperresonance. A normal sound on percussion in the lungs will be resonance. Dullness is when we have consolidation, like in pneumonia, right? And hyperresonance will be when we have too much air, like in pneumothorax. And when we are talking about specifically attention pneumothorax, we are going to have a mediastinal shift and tracheal deviation. Important to remember. Diagnosis, usually just with a chest x-ray, we can see that there is air in the pleural space, but they can also do a CT scan, and they may check the ABGs and check the oxygen. And the treatment, as I said before, a needle or a chest tube. Okay. Atelectasis is another disease. This happens when we have, for whatever reason, a collapse lung, a collapse lung. Causes surgery, airway obstruction, pneumonia. So in many cases we can have atelectasis. The most common is when a patient has surgery. Okay, have you yourself maybe surgery, or one family member, and then you go to the hospital and they have surgery yesterday, and today they are telling you you have to get out of bed as soon as possible, right? So they want people to get out of bed as soon as possible. They give them a little toy to breathe in and out. It's called incentive spirometer. Are you familiar with the incentive spirometer? Yes? Okay, so it's to also do those exercises, also to move often, right, in the bed, to move often, or to get out of the bed as soon as possible. All that is to avoid atelectasis. All those little things that they do for a patient after surgery will be just to avoid atelectasis. So manifestations will be shortness of breath. Diagnosis also can be done with a chest x-ray or a CT scan. And prevention, again, deep breathing exercises like with the incentive spirometer, position changes, and early ambulation after surgery. Now we are moving into different diseases. These are common diseases. Many people have these problems. They are into this group of obstructive airway disorders. We have asthma. We have chronic bronchitis and emphysema. Chronic bronchitis and emphysema will be what we call COPD, or chronic obstructive pulmonary disease, okay, COPD, chronic bronchitis and emphysema. And asthma is also an obstructive airway disease, but it's not considered part of the COPD diseases. Let's start with asthma. Asthma is a chronic inflammatory disorder in which we will see, in addition to inflammation, we will see constriction of the airways, okay? The thing is that when asthma attacks happen often, the airway is going to be remodeling. This means that the airway is going to be changing the structure. Remember when we were seeing heart hypertrophy with hypertension and with heart failure? That was changing the structure of the heart, right? Ventricular, like left or right ventricular hypertrophy. That was also remodeling of the heart. Remodeling can happen in our lungs when we are having several or often attacks of asthma. That's what we want to avoid. We don't want to have any remodeling of the airways, okay? We want to avoid that. How do we avoid that? Having asthma attacks. Okay, so the goal for the asthma is to reduce the number of times that people use the rescuer breathers. Those are SABA. Are you familiar with the inhalers? Are you all familiar with those? Do you know what medication is in there? Okay, there are different ones. So the ones for the rescue for asthma, they are actually called SABA. SABA, they are usually albuterol, right? Albuterol, are you familiar with albuterol? Those are short-acting beta agonists. They are going to be working in the airways, opening those airways to allow the air going in and out. Okay, those are used for attacks, like asthma attacks. Okay, there are other medications that are used for controlling those attacks, to avoid those attacks, but when the attack comes, this is the medication that the patient has to use, albuterol or any of those other SABA medications or short-acting beta agonists. Short beta acting agonists, because we also have LABA. We have also medications that are LABA, which are long-acting beta agonists, which will not be used in attacks. It will be to prevent those attacks. So for attacks, only SABA medication, albuterol or any other SABA medications, okay? So the goal for people with asthma would be to reduce the number of times that we have attacks, or reduce the times that we have to use the SABA medication. Okay, that's the goal. That's why they put in other kind of medications to these people that have attacks often. They will put them in medications that they will control those medications, like corticosteroids or LABA medication or other medications that we are going to see at the end of the asthma chapter. There are many things that are going to be triggering these asthma attacks. Depends on the person. we will have a different trigger. For example, for some people, it's the pollen in the air what is going to be triggering these attacks. For other person, will be emotional states. I'm very nervous. I'm going to get an asthma attack. For other person, maybe exercise. So there is exercise induced asthma attack. So depending on the people. So you have these triggers and more. So what's happening in those airways? What we have is going to have IgE immune-mediated response, which will cause an asthma attack. Let's go to the next slide where I have a little bit more complete explanation of what's happening to those airways. So a person with asthma, we have a trigger, whatever the trigger for that person is, maybe the pollen or the allergen or an infection or emotional upset. What's going to happen is that we are going to have some increase on some immunoglobulin called IgE, right? IgE. We have different immunoglobulins or antibodies in our body. One of them is going to be IgE. So those antibodies are going to be they're going to be located in the surface of some cells that are called mast cells. Mast cells. So those mast cells have granules inside that they are filled with prostaglandins, leukotrienes, and histamines. Okay. So next time that the person encounters again with the allergen, it's going to be bound here, the allergen, and those mast cells, they are going to degranulate, and they are going to be releasing those prostaglandins, those leukotrienes, those histamines. Okay? And that's what is going to happen. That's what is going to be causing this bronchial smooth muscle constriction and this inflammation. So if we have, imagine you have your airways inflamed and there is constriction of the smooth muscle on those airways, what's going to happen? Air trapping. We are not going to be able to do the exchange of gas that well. We are going to have respiratory acidosis. We are going to have low levels of oxygen. We are going to restrict the airways, okay? Is this clear, everybody? Okay. So we have here a picture of the mast cell. It's nicer than mine, but I just wanted to be drawing it. So it's the same thing that I just drew, okay? Again, this slide is going to explain again the same thing. We have the allergen. We are going to have IgE, the immunoglobulin, which is going to be attached to the mast cell. And the mast cell, when there is another increase of the allergen, will be releasing those histamine, leukotrienes, and prostaglandins, and they will cause airway inflammation and bronchospasms, which will cause an airflow limitation. So clinical manifestations of the asthma: chest constriction, wheezing, shortness of breath, coughing, prolonged expiration, tachycardia, tachypnea. And this is again a picture of what's happening to the airways, okay, for all those signs and symptoms, because we have inflammation. In this case, we have inflammation. This is the normal airway. Normal. You see how nice the airway is. We can, you know, the air can go in and out with no problems. However, if we have airway inflamed, you see this airway is much narrower. And then in addition to that, those smooth muscles contract, like here, so that airway is going to be really, really, really narrow. So the air is not going to be able to be moving that way. So that's why we are going to have air trapping. So we classify the asthma depending on the attacks that the person has. And it's important to classify the asthma because this way we can see which medications we can give to each of the patients. So let me summarize this table, and you don't have to learn everything, only the things that I'm going to tell you. There are 4 different categories. We have mild intermittent, we have mild persistent, we have moderate persistent, and we have severe persistent. So we are going to classify depending on how many attacks the person has during the day and during the night. Okay, so how are we going to see that the person has attacks? Because they are going to use the rescuer inhaler. Okay, so we are going to ask, how many times did you use your inhaler in the last month? And then we are going to see how many times. And then, so if the person uses the inhaler or has less than 2 uses during the day, this will be during the day, this will be during the night. So if the person uses less than 2 times per month, 2 days per week, 2 days per week, less than 2 days per week during the day, and less than 2 times per month during the night, that's considered mild intermittent, okay? Mild persistent will be a person that has more than 2 times per week during the day, but less than daily, not daily, okay? Not daily. And during the night will be more than 2 times per month, like about 1 to 4 times per month, so it would be like maybe up to 1 per week. Moderate persistent is when the person is having to use, the person has to use the rescuer daily, every day during the day. And during the night is more than 1 time per week. And then severe persistent is when the symptoms are constant. The person's constantly feeling the symptoms. It's like throughout the day. And then at night is more than once per week. You don't need to know that part of the table, okay? But I probably will ask you, if the person has this amount of attacks during the day and this amount of attacks during the night, tell me in which category this person is, okay? The treatments, as I said before, in order to try to treat the bronchospasms, we are going to use the SABA. If it's an attack, we will be using the short-acting beta agonist. If we want to control and give medication every day to control it, it will be the LABA, okay? LABA. Theophylline is a medication that is similar to caffeine in the size, in the mechanism of action, and is also going to open those airways. And for inflammation, we can use other medications like inhaled corticosteroids, sometimes oral, leukotriene antagonists like montelukast, mast cell stabilizers, and anti-immunoglobulin E antibodies. So you can see how these different medications are going to be working with the pathophysiology of the asthma, okay? So if you relate this to the mast cells, you can understand how or why we would use these medications, okay? So for an attack, always SABA, and then for the rest, for controlling the attacks, like for a daily medication, will be the rest of the medications, okay? So if we have a patient with asthma attack and we want to give 2 medications, okay? We want to give a bronchodilator and also we want to give a medication, a corticosteroid for the inflammation. Which one would you give before? Which one would you give first? The dilator, right? You want to dilate first those airways before giving the other medication for the inflammation. Otherwise, that inflammation medication will not enter that area, okay? So I think that you will learn more about these medications when you see pharm. I don't want to complicate your life here with more medications. Let's move into chronic obstructive airway disease. We said that we are going to talk about chronic bronchitis and emphysema. Those are diseases in which we are going to have, in the case of emphysema, those alveoli are going to be destroyed. Okay, the alveoli, those little sacs are going to be destroyed. In chronic bronchitis, we are going to have a lot of mucus. Okay, so there's going to be, in both of them, there is going to be an obstruction. In the case of the emphysema, it's because the alveoli are destroyed. In the case of chronic bronchitis, it's because we have too much mucus. Emphysema, we are going to have a destruction of the elastin. Elastin, okay? That elastin helps for the recoil of the alveoli. Okay? So elastin is going to be broken down by elastase. Elastase is an enzyme that will break down elastin. So the more elastase we have, the less elastin we will have, and the more, the less recoil we will have. Okay, do you see that? Elastin, elastase break down elastin. If we break down elastin, we will not have recoil of the alveoli. Do you know what's the recoil of the alveoli? Okay, so it's like going like, we're going to see that in the next slide. So I just want to say that, and elastase. And then we have too much elastase when we have low alpha 1 antitrypsin. So 2 different causes of emphysema. One of them is going to be genetic when we have not enough alpha 1 antitrypsin, and another one is going to be smoking. Smoking and decrease of alpha 1 antitrypsin will increase the amount of elastase. If we have too much elastase, we are going to have too little elastin, which is the protein that helps for the recoil of the alveoli.
Say it again.
2 different things are going to be affecting the recoil of the alveoli. So 2 different causes for emphysema. One of them is going to be genetic. One of them will be too little alpha 1 antitrypsin, alpha 1 antitrypsin deficiency. That will cause too much elastase. The other one will be smoking. Smoking and alpha 1 antitrypsin deficiency, both will cause high amount of elastase. If we have a lot of amount of an enzyme, we will have too little elastin, and that protein helps for the recoil of the alveoli, okay? What's the recoil of the alveoli? So this is a normal alveoli. So when the alveoli gets inflated with air, has this shape, the long one, and then when the air leaves the alveoli, because it's going to be leaving the body, the air, then the alveoli gets recoiled. You see, this is when the alveoli is recoiled. What's happening in emphysema is that this recoil action of the alveoli doesn't happen. So the air gets trapped in here. There is air trapping in emphysema because that alveoli doesn't recoil. Why it doesn't recoil? Because we don't have enough elastin. Why we don't have elastin? Because we have too much elastase. Why do we have too much elastase? Because the person smokes or because the person has a genetic disease with a decrease on the amount of alpha-1 antitrypsin.
So their body's going to have a lower pH there?
So we are going to be having probably acidosis, right? Wait, we are going to talk about emphysema a little bit. Don't run into the pH because that in emphysema doesn't happen until later in the disease when it's advanced, okay? So characteristics of pulmonary emphysema. Smoking, right? Smoking history. If the person is a young person that doesn't smoke, I will be thinking about a genetic disease. If the person smokes and tells me that the person has been smoking for 25 years, I may be thinking about emphysema. The person is having a weight loss, chest, barrel chest. You know what that is? Barrel chest. What? Barrel chest. Decreased breath sounds. And then the gases, the ABGs, are going to be normal until later in the disease. At the beginning, they are going to be able to compensate very well. They don't have any ABGs problems. Later on in life, they will be having problems. Also, these patients may end up having cor pulmonale, which is the right-sided heart failure when there is a problem with the respiratory system, okay? But also in advanced cases. Those two are for advanced cases. This next slide is what I just explained you about elastin, elastase, alpha-1 antitrypsin, and smoking. So you can read it again, but this is what I just told you before. Again, clinical manifestations of emphysema, the barrel-shaped chest, again. Decreased breath sounds, and the ABGs are normal until later in the disease. Here we have a picture of what a barrel chest is. If you don't remember what barrel chest is, here it is. And the diagnosis is done by checking the pulmonary function test. They can check the ABG, but as I said before, not until late will be abnormal. The treatment, can you think about the treatment? Stop smoking, right? Stop smoking. Nothing we can do with a person that has a genetic problem, right? But for those people that have a problem with smoking, that would be the time to stop smoking. And then we will be using different kind of medications like corticosteroids, bronchodilators also, inhale anticholinergics. And as I said before, for these people, we can give some oxygen, but there is going to be a low flow of oxygen for those people. Why? Because oxygen is going to be the drive for breathing. So if we are giving them a lot of oxygen, they are going to lose that drive for breathing, and they are going to decrease the respiratory rate down to very low levels, which could be dangerous. They can have surgery, and they can also apply for a lung transplant. Moving on into chronic bronchitis, which is the other disease for COPD, right? In this case, there is also air trapping, but the air trapping is caused by mucus. It's nothing to do with the recoil of the alveoli. Here we have a problem with the mucus. And then you can see here, which is the definition of chronic bronchitis. Hypersecretion of mucus and chronic productive cough for at least 3 months of the year, for at least 2 consecutive years. So that person that is coughing constantly, they get up in the morning and they cough, and then they cough stuff. Those are the ones that are diagnosed with chronic bronchitis. In this case, with chronic bronchitis, remember with emphysema, I told you the ABGs and the cor pulmonale only happens later in the disease with very advanced disease. In this case, with chronic bronchitis, those ABGs and the cor pulmonale happen earlier in the chronic manifestations, wheezing, coughing, productive coughing, productive coughing, very important, pulmonary hypertension. And this is the same thing, what's causing this chronic bronchitis? Smoking for all of them, smoking a lot. They smoke a lot, so the airways are going to start producing mucus, and what's going to happen? That mucus is going to be blocking the air going in and out. So again, we are going to have air trapping, but in this case, it's not caused by this problem with the recoil of the alveoli, but with those mucus that are blocking the air from leaving the alveoli. The diagnosis, again, pulmonary function test. And the treatment, bronchodilators, corticosteroids, smoking cessation, that's the first one, right? I should have marked. And of course, they need to be vaccinated to avoid any extra complications for those people. Usually people with emphysema are called the pink puffers. Pink puffers. They are called like that because they use the pursed lip technique to breathe. So they would do like, to be able to release all this air that was trapped in the lungs. And they are pink in comparison with the blue bloaters. Those blue bloaters are the chronic bronchitis, and they are called blue because they may have cyanosis and polycythemia. They may end up with cor pulmonale too. Polycythemia, they have polycythemia. Do you know what polycythemia is? This is high levels of hematocrit and hemoglobin. Can you think about a reason why they have polycythemia?
Trying to get more oxygen.
Yeah, they are trying to get more oxygen to the different cells of the body. That's why they are creating more red blood cells, more hemoglobin, more hematocrit, okay? To compensate. Do you have any questions? Everybody's okay? So the last part of the pulmonary chapter is going to be related to pulmonary vascular diseases, okay? When we look at this slide, we can see here a very nice picture of the circulatory system. When we talked about last week about cardiovascular system, let's review a little bit about cardiovascular system. Remember when we had a person with hypertension, what's going to happen to the left ventricle? It's going to pump harder, right? It's going to be pumping harder. It's going to be a left ventricle hypertrophy, remember? So more oxygen we are going to need to feed that large left ventricle, which eventually we will not have enough oxygen, so the person will have problems ejecting the blood, right? So we can end up with heart failure, right? So the same can happen if the person has hypertension, but in the pulmonary arteries. So if the person has pulmonary hypertension in the pulmonary arteries, again, the right ventricle has to be pushing hard, right? So we are going to end up with what? Right ventricle hypertrophy, right? And then again, we may end up having, we will need more oxygen. There is not going to be so much oxygen, so we will end up with right-sided heart failure, right? Which is called cor pulmonale, okay? So this is just an introduction for those three different diseases. Pulmonary embolism, pulmonary embolism is different, but for pulmonary hypertension and cor pulmonale. Let's start with pulmonary embolism, okay? Pulmonary embolism. Do you remember when we talked about cardiovascular last week, what was the risk factor for pulmonary embolism? Pulmonary embolism? A DVT, right? Remember what DVT was? Deep vein thrombosis. We have a thrombus in a vein, right? We have a thrombus in a vein. What's going to happen with that thrombus? It's going to get dislodged, right? Where is it going to go? To the lungs. What are we going to have? Pulmonary embolism. Remember, we are going to have that capillary area blocked, so we will not be able to do the exchange of gases. That's where the problem comes. Sometimes it's not a thrombus what is causing that pulmonary embolism. Sometimes it's fat. Okay, so if we have a long bone broken, the bone marrow is going to be going also somewhere else. It can go all the way to the pulmonary circulation and cause also pulmonary embolism. Also, amniotic fluid. Amniotic fluid, the woman that is giving birth. That amniotic fluid sometimes can go also all the way to the lungs and cause pulmonary embolism. Okay, so it's not only thrombus what is causing that pulmonary embolism. There are other causes that are less common, but still it can happen. And of course, if the risk factor, when we're talking about risk factors for DVTs, remember this white course triad? We're going to have the same risk factors for PE, because PEs are caused by DVTs. So this is a different one for a white course triad, but again, it's telling you the same thing. We may have a person with hypercoagulability when the person has when the person smokes or sepsis. Remember another reason for hypercoagulability? Estrogen therapy, right? Estrogen, right? Or testosterone as well. Sometimes testosterone. Endothelial injury, when we have damage to the endothelium, we can have this when we have hypertension, right? Hypertension may be causing this endothelial injury. Venous stasis, when we have the blood staying for a long time, when we have immobilization, when we have bed rest, when we have a long flight, when we have a person with atrial fibrillation, right? Atrial fibrillation, that's why those people with atrial fibrillation are on anticoagulants, right? Like what? Like Coumadin, right? So they are avoiding, they are avoiding the blood to become thrombus or an emboli, okay? So this is the Vickers triad is important, okay? Clinical manifestations of a PE would be chest pain, dyspnea, tachypnea, tachycardia, and the diagnosis can be done with D-dimer. It could be done with an EKG, at the scan of the ventilation perfusion, sometimes with an MRI or CT scan. And the treatment, of course, preventing the DVT, so it's important to know the risk factors of the DVT. When we have already the thrombus there, we can use TPA, right? TPA is going to dissolve thrombus. Anticoagulants, they will not dissolve thrombus, but TPA will dissolve those thrombus. Yes. So the person may be in anticoagulants, but remember the anticoagulants are not going to be dissolving any clots. They will prevent new ones, but they are not going to dissolve anyone. And then also IVC filters, okay, IVC filters. This means inferior vena cava filters. So a person that is having many different times pulmonary embolism, they may put a filter in the inferior vena cava to collect all those thrombus that are going all the way to the lungs. So they will not reach the lungs, they will be caught there in the filter, okay? That's also common, that happens often. Any questions? Let's keep going with pulmonary hypertension. I already explained you a little bit about this pulmonary hypertension, right? So what's happening? We have high pressure within the pulmonary artery. So what can cause this high pressure in that pulmonary artery? Sometimes it's unknown, sometimes it's something genetics, sometimes some drugs can also cause this pulmonary hypertension. But remember what I told you the other day, the main reason for right-sided heart failure is left-sided heart failure. So a reason for having pulmonary hypertension, it could be that blood that is backing up all the way to the lungs. That can cause pulmonary hypertension. Signs and symptoms, right ventricular hypertrophy, right? So when we see a person that in an X-ray or in an EKG has right ventricle hypertrophy, we may be thinking about the person having pulmonary hypertension. Fatigue, chest discomfort, tachypnea. Again, remember this is the right ventricle, right? You see the difference between a normal right ventricle and a right ventricle that is hypertrophic, okay? Yes?
How would preload and afterload have an effect on the pulmonary hypertension?
So preload is the amount of fluid that we have in the body, right? So if we have a lot of fluid and it's getting back up in the lungs, that will be affecting this. It will cause pulmonary hypertension, right?
Yeah, the right ventricle is too much in right vacuum.
Yes, and then the afterload. Afterload is the
Pressure needed to push it into the circulation.
very good. Yes, the amount of force that the ventricle has to done to overcome that pressure in the artery, right? So in this case, afterload is going to be high because, and then that's why the ventricle gets hypertrophic because it has to overcome that strength. So it has to do a lot of effort and strength, and it's like the heart is going to the gym, right? So that's why it becomes hypertrophic. Yes, good question. So when this happens, when we have right ventricular hypertrophy, or when we have pulmonary hypertension, is when we may have core pulmonary. So core pulmonary, we have core pulmonary when we have right ventricular hypertrophy caused by pulmonary artery hypertension, which will cause eventually dilation and failure of the right ventricle. Okay? So in this case, is when the left ventricle is working well, okay? We have nothing to do here with the left ventricle. It's happening only in the right ventricle because there is something wrong with the pulmonary circulation, okay? So we will have pulmonary vasoconstriction, right ventricular hypertrophy, decreased oxygenation. We are going to have more red blood cells to compensate, and the workload of the heart is going to be high. You can read from this, but it's just core pulmonary is caused by pulmonary disorders. The pulmonary disorders are the ones that are going to be causing the right ventricular hypertrophy, okay? And so it's going to be right pulmonary hypertension, and then we will end up with right ventricular hypertrophy. Manifestations, chest pain, EKG probably will show right ventricular hypertrophy. The valves may start working bad because they are going to be backing up blood, so the valves may be having some problems opening or closing, which will be heard as murmurs. And the treatment will be to decrease the workload of the right ventricle by lowering the pulmonary artery pressure. So we will have medications to decrease the preload and medications to decrease the afterload, okay? So medications to reduce the amount of fluid that we have in our circulation, and also medications to reduce the amount of pressure that we have in those arteries. And this is the last disease that we are going to talk about today. Is called ARS, or acute respiratory distress syndrome. It's called ARS, okay? This is a response to other numerous conditions. So it's not something that someone will have just because the person has ARS. This is coming from other diseases. This is coming from a person that has sepsis. This is coming from a person that has shock. This is coming in a person that is really sick. I see people with ARS in the ICU, okay? They have to be in the ICU, but it's a result of other diseases. So what's happening here, this is an alveoli, right? This is alveoli, and then here we have the capillary. The alveoli has epithelium covering that alveoli, and the endothelium, remember, the capillary have endothelium. So what's happening is that that endothelium and that epithelium of the alveoli are not functioning well, and there is going to be a leak of proteins and fluid from the capillary, and it's going to go all the way to the alveoli. So the alveoli of the lungs are going to be filled up with proteins and fluid. And it's going to be not like in pneumonia that we have an area only with lung consolidation. Here, all the alveoli are going to be filled with fluid rich in proteins. So causes of ARS, okay, cause. It could be a person that almost drowned, the person with pneumonia, sometimes when it goes bad, pneumonia, trauma sometimes, but most of the people that I see with ARS are people with sepsis and shock. You know, sometimes with DIC as well, burns when they are massive burns. Fat embolism sometimes also can cause ARS. Manifestations. This is how they progress. Okay, the patient is already sick for whatever reason, for another reason, okay? And this is going to be a disease that is going to progress. First, we are going to see that the person has shortness of breath and low oxygen levels. Then later, we are going to have the patient that will hyperventilate, right? Because the person has hypoxemia, right? The person is going to increase the respiratory rate, right? Hyperventilation. And that's going to end up in the patient showing up as respiratory alkalosis, right? Low CO2, right? Low CO2, okay? Everybody's following, right? Then we are going to have a decreased tissue perfusion, which will show as metabolic acidosis. The person is going to try to increase the work of breathing, but it's not going to work very well, and the person will end up with hypoventilation and hypercapnia, so high CO2, which will be shown as, of course, respiratory acidosis, and the person will end up with respiratory failure. The goal is to catch the patient in any of those states when we can do something without having the patient going all the way to respiratory failure. Okay, so it's the goal of everybody in the hospital will be to be alert in this point to prevent any further problem. And this is just look at it. I'm not going to ask anything about this. I just put here in red what are the important parts. We have alveolar collapse. Those alveoli epithelium is going to be broken, and there's going to be a collapse of the alveoli. And then we are going to end up with hypoxemia, which is low oxygen that is going to be refractory to supplemental oxygen. So even though we are going to give the patient a lot of oxygen, still the patient will continue with hypoxemia or low oxygen. Why? Because those lungs, the alveoli, are filled with fluid rich in protein. So even though we are giving a lot of oxygen to the patient, that oxygen is not going to be reaching the blood, okay? No way. Those alveoli are filled with fluid. And then this is how it will be showing a person with ARS. Tachypnea, dyspnea, retraction, hypoxia, tachycardia, and low pulmonary compliance. Of course, the person will be on a ventilator. And when they do a chest x-ray, they find the lungs are white lungs, completely white. All the lungs are totally white because they are filled with fluid rich in protein. So that's how they look, white lungs. And these are the different reasons for a person to have ARS. Again, this is a low oxygen, low partial pressure of oxygen, and the patient is not getting better even if they give a lot of oxygen to the patient. And this is the end of this PowerPoint.